You're going to decide what services you want to be included. And according to the services, you're going to be paying more for the service. So here is the same. But schedule of benefits, nothing else than all the services that you can receive, that your insurance cover you for it. So that's basically what it is. All the services that you're going to get, they will be written in that contract. So that's what is called schedule of benefits. Be careful with these terms because these terms are very important, at least for you to understand when you get your insurance and when you go to your medical doctor and they said, oh, this service is not covered by your insurance, don't get upset. This has nothing to do with the doctor. This has to do with insurance that you have, the plan that you select, or the plan that was assigned to you. So unfortunately, that's how it works. So if I have a plan with my carrier, my insurance company, they're going to cover certain services. Well, the basics, of course. But there are some services that are going to go beyond what the insurance can pay for my services. So for instance, if I want plastic surgery, my insurance is not going to pay for it. This is not a medical requirement. This is not a medical necessity. So again, there are some services that I'm going to be covered for certain plans, others are not. So that's what we call schedule of benefits. So just keep it in mind. You're going to have these patients coming over, and when you tell them, oh, you need a referral to get this procedure. Now, hey, you didn't get the procedure, it was denied. So the insurance don't want to pay for that. The patient is going to get upset. So you're going to explain them. Your contract does not include that. So with your insurance, that's the plan that you have. That's it. Or say nothing. Send them to the billing department because the billing department is the one that has to deal with them when it comes to insurance. Remember, don't get involved with things that you're not familiar with. Even though if you understand some of the things that I'm telling you, sometimes it's better to refrain yourself from giving information to the patients because when the patients are upset, they don't want to listen to you. You can tell anything. No, my insurance pay, and I don't know, last time I got this service. Remember, sometimes you have services that are limited. You have certain amount of visits that you can use during this period of time. They give you a window period, like 6 months. In 6 months, you can go see the doctor, your general practitioner, your PCP, 10 times. They give you the number of visits, and they will not go beyond that. When you surpass that, the limitation, and you're going to go back again, your insurance is going to deny that. You're going to show that you don't have coverage anymore because you already got all the visits that were assigned to you. Think about if you pay a plan on your phone and you have a limited data, limited call, limited testing, limited internet. Well, that's exactly what's going to happen when you meet the required, services that already, you pay for it and you get to that limitation. That's it. You're not going to be able to have more services. You have to go and add more money. Here it's not that you're going to have more money. You're not going to get paid for those services. So we're not going to get paid, so we don't do the service because it's not covered. So that's important for us, not just for our patients, because we are going to be dealing with them because they're going to be paying with the insurance when they come to receive services. So we understand now what is the reason why. You can have your insurance card that is valid for 6 months. Yeah, it is valid, but you already use all your visits. You already use all your procedures that were assigned for that particular period of time. So this is something that usually we don't know. Why? Because when we get insurance, they don't tell us all this. They just tell us, okay, you need this and you got covered for this and you can use it and we assign you this doctor. That is it. So we are happy, right, that we have the service. But then there are certain things that are not covered by the insurance because it's not written right here in this schedule of benefits. That's what it says, schedule of benefits. What is the benefits that you're going to receive having this insurance? That's basically what it is. Capitated procedures. Now, capitated procedures is different from schedule of benefits. Remember, schedule of benefits is going to tell you what services you are entitled to receive as an insured, as a policyholder. That is basically what it is. A capitated procedure. Now, this is how we, with the insurance company, pay the medical providers for each patient. This is a fixed amount of money that the insurance pays the medical provider for the services of their clients. Let me use other terms. Let me give you examples. So let's say we have, all these are managed care. Remember, it has to be. Private insurance do not have capitations. This is for governmental insurances. So capitated means that, the medical doctor, the hospital contracts with the insurance company or with the HMOs, the health maintenance organization, and they're going to tell you, okay, so we're going to pay you this much for each patient every single time the patient comes for a visit. We're going to pay you this much. They pay for the services. So we have Medicaid and we have Fidelis. We have Metro Plus, Health Plus, United Healthcare. There are other HMOs out there. These plans under Medicaid, they are capitated because this is government fund organizations. So the government is not going to pay much to the medical providers for the services of the patients, even though if they receive the same services as someone who pays through their group or their employer or through your self-insurance. So let me give you an example. Fidelis. Fidelis pays $30 per visit to all its patients. To all its patients, $30 per visit. So that is it. What does a private insurance or group insurance pay? $150, $200 per visit. So you see, now they are capitated. They are fixed. So in order for me to make money, I have to have lots of patients. Can you imagine each patient? Wait a minute. They pay not per visit, per month. I forgot. It's per month. Whereas private insurances pay per visit, and they pay $200. Depends on what office is that, where it's located. That's why many medical providers, private offices do not take HMOs. Why? Because they pay cheap. Remember, they paid $30 per month per patient. Whether the patient comes to the office 10, 20, 30 times per month, we're going to get the $30. If the patient comes once, we're going to get the $30. If the patient don't show up during the month, we're gonna get the $30, as long as the patient have coverage. It is very, very small amount of money. So that's basically what it is. So that is capitation. Any questions about schedule of benefits or capitation? Because capitation is one of those questions that might come out in exams, because it's a fixed rate that the insurance, the HMOs, pays to the medical providers for their patient services, for their client services per month. So that's how it is. Okay, so what are the things that should be listed in each of these managed care contracts? It has to have lots of stuff right there. Because I'm gonna pay for this, I'm gonna pay for this, I'm gonna pay for this. That's exactly what you're gonna see in that list. Now, remember, patients are not aware of all these things. They just say, okay, so you have an insurance and you can use it. They tell you a little bit about what coverage you're gonna have, but that's about it. The reality is when you encounter yourself in a situation, now you have all these issues about getting a referral, getting a pre-approval, or deny your coverage. So that's basically what it is. So things that are needed, CPT codes. CPT are these procedural codes. This is billing and coding. But if you were going to bill the patient, because this is insurance, billing is part of insurance, is part of the insurance part. So we're going to have CPT codes, and it says right there, procedure codes and rates for each service. So whenever I do, remember, this is for procedures. If I draw blood, if I do an EKG, if I do Pap smear, if I do colonoscopy, if I do any of those procedures, anything that includes doing a procedure is called a CPT code. That's what it is. So again, we're going to use those codes to complete the claim for reimbursement. This is what we're going to be sending to the insurance company so we can get paid. So instead of writing down EKG as the procedure, we're not going to do that. We're going to use code that represents, because these software applications do not interpret handwriting. They interpret no letters, no text. They interpret codes. So that's basically what it is. And that's what the biller and the coder do. Transcribe all these texts of diagnosis and procedures and services into codes so we can get reimbursed. Now, we have a time limit to submit those claims. Well, think about it. Your medical doctor is not going to wait, because usually it takes 30 days for us to get reimbursed if we were lucky. If we have a commercial or private insurance, we get paid prior to 30 days. But if it is this HMOs, it's going to take up to 2 months, 3 months to get paid if the claim was completed correctly. Otherwise, they're going to return the claim and we have to resubmit it again until we meet all the requirements. So that's basically what it is. So we have up to 90 days to submit a claim to the insurance company for the services provided for our patients. See, one of the good things that we have about electronic health records is that, the claims, we send the claims daily. As soon as we review the diagnosis, the procedures, the biller sends the claim to the insurance company, and we get the money right away. Well, not right away, but at least within a week versus, mailing them and sending them and completing. That takes a long time. But for us to be compensated. So if you take more than 90 days for billing this patient, this insurance company actually can deny the payments for those procedures or services, whatever the case may be. But you know that the medical doctor is not going to take too long to submit all these claims for the services provided because, well, this is business and business needs to run with financials. So patient that is seen, patient that claim that is completed, and claim that is submitted to the insurance company. So they can review it and they can pay us, they can reimburse us. In order for us to do that, we have, well, actually, we're going to talk about two types of forms that we're going to use. We're going to use the CMS 1500. That's the most common one for outpatient setting. And the UB04, which is for hospitals and large organizations where they have inpatient services. These are forms. We're going to be using the CMS 1500. I'm going to be sending to you at the end of this week, because next week we're going to be learning how to complete that form. It is an electronic form. So you just need to enter in each one of these windows in front of each of the items that is asking you something about the patient. So we're going to complete that form. So that's important. So you can have a little understanding of how these claims are completed and where do we get the information from to complete these claims. Remember, medical records, something that we call encounter form or super bill. We will discuss that when we get there. So again, there are two major important forms. CMS 1500. CMS, this is from the Centers for Medicaid and Medicare Services. That's what CMS stands for. Centers for Medicare and Medicaid Services, because they are the one who created these forms. And UB stands for Uniform Bill. So it's a form that usually is standardized, is uniform for hospitals or large organizations. That's basically how it is. But the most common one for outpatients, we're going to talk about the CMS 1500. So we have to meet lots of requirements in order for us to, to complete these claims. We need to know what insurance is it and how much we can expect being paid, because the billing department knows more likely how much we're going to get reimbursed for the services. Remember, in the office, we have values for services, because we're going to use, remember, the usual, the reasonable, payments, but the insurance is going to have the last word. They're going to decide how much they're going to reimburse us for each of these services, depending of, the specialty, the medical provider's location, and whether it's usual, customary, or reasonable. They are based on all those factors. So that's how it is. So there are certain forms that has to be submitted, and these are the only ones that the insurance is going to receive, because they are the ones that are accredited or required by the Centers for Medicare and Medicaid Services, both of them, the CMS 1500 and the UB 04. So managed care plan credentialing. Now, when we talk about managed care, remember, this is a national, this is a federal, this is a government that institutes these credentials. These are the ones who are, monitoring that the medical providers, they don't have any disciplinary actions or malpractice history, because they have to make sure that whoever is providing these services to their patients, or the ones that are under these managed care plans, they have all the qualities to render the services. That's basically what it is. So in other words, these managed care organizations, MCOs, reviews the provider's background. They check if you are being accused for fraud, any other criminal activity. Again, disciplinary actions meaning, the committee of ethics committee has, brought charges on you, or patients brought charges on you for malpractice or negligence. So that's basically what it is. Every single medical provider is being graded, just like you are graded every single time that we complete these chapters with the final exam. They are graded in their performance, how they are, if there are no complaints about it, if there is no issues, if the hospital as a whole has no complaints. Because remember, we are part of the hospital, but if someone within the, the staff, that's something illegal, is going to reflect on the hospital as a whole. So that's basically what it is. So they're not going to be kind of balancing out who is the best provider. That's not what they're going to do. They're going to make sure that the patient receives the quality of care that they deserve, so that you don't get them in trouble, that you complete your medical records on time. So that's basically what it is, that you do not misdiagnose the patients. So there is an organization that is monitoring what the hospital is doing in regards to, once again, quality of care. So we talk about medical law and ethics. So here is a little taste of, kind of recap of what we already covered. So it's very important for the people who works particularly in the billing and coding department, because this applies for medical insurance. Remember, if you do not provide, the services appropriate to the patient, then, the patient is going to have some medical consequences. And we're going to pay for it, because probably going to be sued by the patient or the family of the patient if the quality of service is not up to standards. So that's basically what it is. So we're going to talk about these ethics, which are a set of values of standards for which we evaluate each of the members of the medical profession. So that's basically what it is. Depends on how the medical provider behaves, how they act in regards to the quality of care that they render to the patient. Remember, you should not be discriminating your patients based on any circumstances, race, religion, politics, gender, physical or mental disabilities, sexual orientation. You can't do that. Whether the patient have insurance or not. If it is an emergency, we cannot deny services. So that's part of the ethics. Now, for us, let's say for the insurers or the insurance of billers and coders, it applies the same. Because we should not, use codes that are not the appropriate ones to bill for services. Remember, we are the one who needs to translate those text diagnosis procedures into codes. And if you don't do it correctly, then you can affect the process of receiving reimbursement or the patient receiving services that are appropriate for that condition or any conditions that they may have and treatment is required. So that's basically what it is. Biller and coders, they call, the specialist, because you have a specialty, which is being a biller or a coder. Well, it is your obligation to know and to be familiar with the patient bill of rights. This is not something that you have to put it on the side. Just because you work in the administrative part of the medical does not imply that ethics do not cover you. You have to apply them anyways. So law and ethics, medical law and ethics is going to follow whatever you're doing, whenever you are interacting with the patients, whether directly with the patients or through the financials. So remember, we have some codes that we're going to be reimbursed for it. And sometimes we might be thinking more about the money that we want to get reimbursed versus, the condition of our patients. So that's basically how it is. So law and ethics, very important to follow in any circumstance. So here are some of the things that we should be looking out for, particularly when you are coding, when you're filing these claims for reimbursement, because there are lots of fraudulent situations when it comes to billing patients. Later on, we're going to talk about some of the names that we use when you use different codes to get more money for the services. So we can do that. So that's the most important thing. Remember that the medical doctor is the one that, is going to be writing down procedures, diagnosis, treatments, and we have to translate that to codes. But if we notice something that is not right, we have to bring it to the attention of the medical doctor. In good faith, of course, without insinuating that, they are probably doing something wrong. It might be, a mistake. Many medical doctors do not know about codes. So they might just give a, information that you might not be able to understand correctly, so you ask for clarification before anything else. The doctor probably wrote something else and you interpret it differently. So when you notice something that you do not understand, you should, as a biller specialist or coder, you should discuss this with the medical doctor that actually entered this information in the medical record. Remember, we're going to get the information from the medical record. So that's basically what it is. Remember, the consequences are serious. It's not just the medical biller, the medical doctor, the office, everybody is going to pay the consequences for fraud. And medical fraud is more common than you might think. So you have to be careful when you're dealing with billing and coding, because that was the problem. There's problems everywhere, but there you can actually do it intentionally because you're going to benefit the practice, because you're going to receive more money for the services provided, particularly taking in consideration that some of the insurance companies don't reimburse you much for the services. So you might, upcode certain services just to get reimbursed more money, which is illegal. Okay, let's leave the medical ethics to the side and let's continue again with these managed care organizations, because that's the one that we are discussing right now. That is the most limited. And it's the one that, because it is funded by the government. So the government is keeping an eye. This is state and federal laws that are monitoring all these services to make sure that not only quality to our patients' care is being rendered, but to prevent fraud from services not provide. So that's basically what it is. Benefit plan. Now, think about, do I'm gonna get benefits? That's what you ask when you apply for a job. What are the benefits? So think about that. So benefit plans is a program that provides benefits to employees. It might be a retirement plan, like 401k. It might be your insurance. What benefits I'm gonna get? So that's basically what it is. And it is a legal contract, remember. It is legally enforceable. Now, by who? Well, by law, but also by the person that promised you or offer you those services. So that's basically what it is. If you offer me this plan, you have to deliver, because there is a contract right there. It is part of these managed care organizations to protect, the employees from the employers if they don't render the services that are written within the contract. So that's basically what it is. So that's a benefit plan. So that's good for us, because when we get a job, we're going to be able to read what benefits we are going to be eligible to receive. So pay attention to all this. This is very important. So let's talk about other terms used in the managed care organization contracts. Contracted services. Now, contracted services means what are the services that you are covered as a medical provider? That's basically what it is. Depending on your specialty, your level of training. That's basically what it is. So when we got services, because these insurance companies pay for services provide not just for medical doctors, they provide for other licensed people. So you don't have to be a doctor to get reimbursed. Well, they're not going to reimburse you directly, but they're going to reimburse you for the services on behalf of the hospital or the institution for the one that you work for. So that's basically what it is. So that is contracted services. Whatever services you contract with the insurance company, you know, they're going to provide those services, but you have to have certain type of license. So you can attest that you actually, you are credentialed to provide those services, that you are credentialed to receive a reimbursement from the services that you will provide to patients. So that's basically what it is. Now, let's talk about this one, because this one is in yellow. I mark it over there because this comes in exams. They like to ask about this.
Can you open the back door, please?
Oh, do you ask me something? Coordination of benefits. This is important, remember. It's going to be on your exam, so you need to understand what is coordination of benefits. Now, when we talk about coordination of benefits, remember, it is a process that determines which healthcare benefit or insurance plan is responsible for paying your services. So when we coordinate benefits, means, okay, if I have one insurance, a primary insurance, well, that's the only one who's going to pay. But now, if you have insurance, what if you don't have? Then you're going to be a dependent if your spouse has insurance. So here the key is who will pay for your services. Remember, there is only coordination of benefits when you have insurance. If you don't have insurance, that doesn't apply because you're going to pay from your pocket. You're going to pay cash. Whether you use debit card, credit card, check, money order, it doesn't matter. That's cash. You're not using an insurance company to reimburse the medical provider for the services that you receive. So when we coordinate benefits is when we see who is going to pay for your services. When we said who is the insurance, which insurance plan? You have an insurance, you have a secondary insurance. If you have only one, that will be responsible for it. If you have two, who is going to pay the highest amount? Because if you have two insurances, remember, it's not that you actually get two insurances, you might. Hello? Somebody asked me a question. So remember, this coordination of benefits is very important. So if you have one insurance yourself because you are working or you paying for it, or you have a government insurance, then that will pay for your services. If you do not have insurance, but your spouse have insurance and you are covered under that insurance, so you are dependent. So that will pay your insurance. That will pay your services. Now, if you have both primary and secondary, the secondary might be a secondary insurance that you purchase or your spouse insurance. Both of you have insurance. So one is going to be the primary, the other one is going to be the secondary. So when we coordinate benefits is to see who is going to pay for the services, depending on whether you have one insurance, well, we just call that's the only one who's going to pay. But whatever balance you have to pay from your pocket. But if you have secondary insurance, the primary one is going to pay the highest amount, and the secondary is going to cover the balance. You cannot bill the secondary insurance, never. Well, you can bill it, but you're not going to get reimbursed because that's not your primary insurance. The insurance company knows, oh, I have my wife's insurance. They pay better. So that's my secondary because I have my own insurance. So then I said, oh no, I'm going to put my wife so I can pay less. No, that's not how it works. The insurance immediately rejects that claim because you send the wrong insurance or you mix them up, whether intentionally or unintentionally. They're not going to pay. So that's what's called coordination of benefits. Which insurance, the one that you have, whether it's only one, then that's the one that pays. But if you have multiple insurances, you get your primary insurance, but you got a secondary insurance. You can do that. People do that. So again, it's just to see which one of the insurances is going to pay the largest portion of the services. Remember, the primary insurance is going to pay the largest portion. If the secondary, if you have, it will pay the balance that the primary insurance did not cover. So that is coordination of benefits, remember. So this is a question for exam. So for that reason, kind of, try to explain it to you so you can understand it better. It's very important that we understand coordination of benefits. And don't mix them up with other terms that we're going to find later on that are very similar, but it's not the same. So that's basically what it is. If you have more than one insurance, then you need to know which one is the primary, the secondary, the tertiary, whatever else you have. And you have to file the claims correctly, appropriately. Remember, if you misuse or you make a mistake and you put the secondary where it's the primary insurance, your insurance is going to be denied. And if the insurance is going to be not denied, it's going to be rejected because it's going to be sent for correction. So now we have to review the claim again and see what was the error, because they're going to tell you, the insurance is going to tell you. Item number 10A, you have the wrong insurance. So then immediately said, oh, wait a minute. I used the wrong insurance. Oh, wow. Oh, I mixed them up. So now he said, oh, the primary was supposed to be first and the secondary second. Well, of course, makes sense. And we have consequences. Not only that, we have to do the work again. We have to go over and review and try to get the team straight, do the correction, and resend this claim again to the insurance company. So that's going to take time for us to get paid because things were done the first time. So that's not going to be good. And that's not going to be good for the biller and coder specialists, because you might get fired because you're not doing the right thing. We're not getting paid. That's the most important thing when we render the services. What is the most important thing when you work? You're going to get paid. And can you imagine the day that you're supposed to be receiving your pay, your salary? Oh, they're going to tell you, oh, I'm sorry, we made a mistake, but you're going to have to wait. You're not going to like it. So the same goes for the medical office or the hospital. If you don't complete this correctly, then now we have to wait for reimbursement. So not good. Let's talk about this term because this also is part of the exam. You need to know, remember, coordination of benefits. You need to know for your exam. Copayment. So what is a copayment? You're probably familiar with copayments. Think about you're going to buy a property. You're going to buy something that you cannot afford it to buy it cash, or you just don't want to pay cash for it. And you're going to take, installments instead. So that's similar. You're going to give a down payment. Oh, you're going to buy a car. But I cannot pay all these amounts. It's too expensive. So I'm going to say, how much are you going to give down payment? Oh, $1,000, $2,000. Well, whatever is required. And then you start paying installments, right? Monthly. Well, the copayment is similar. In this case, for insurance. This is a charge or amount of money that the patient has to pay every single time that you receive services. Every single time. That is the copayment. That's the answer. What is the amount of money charged to the patient in every visit? What is called copayment. That's basically what it is. All these commercial private insurances have a copayment. Not long ago, Medicaid had a copayment, not anymore. But they used to have a copayment. For some medications, they do charge you a copayment. Oh, you have 2, 3 medications, they charge you $3, $4, $5, $7, $10, that's it. But we are talking about copayment for the visits. So if you have an HMO, usually you don't have a copayment. So that's basically what it is. But in general, don't think that because you don't pay copayment or because you heard that every single time this person goes to the medical doctor, they don't pay anything. That's not what we're talking about here. When you get a question about the amount of money that is charged to the patient every single time they receive services or just visit the hospital, the clinic, we're going to charge you a copayment. That's basically what it is. Back in the days, they charged $5, $10, $15. Now it is $20, $25, $50. Emergency is the most expensive. An emergency, they charge you $50 and up, depending. Doctor's offices, they charge you $20, $25. Sometimes $15, but they go like, that's the copayment. And that's something that you as a medical assistant needs to do. Every single time that your patient comes to the office, whether it's new or not, they have to pay copayment. If they have a copayment charge. The insurance card of the patient is written right there. It says medical visits, $15, $20, $25. So you can ask, the patient knows. Oh, hi, Mr. and Mrs. Smith. So you have a copayment. Are you going to pay now? Because usually we collect it right there at front. Because after the patient is finished, probably it's going to be gone. But before you actually register them for that visit, you have to ask them. You review the insurance. You know that the patient has coverage now. Oh, by the way, you're going to pay the copayment now or later? So collect those copayments. That's how it is. We have to collect copayments. So that's the amount of money that you're going to charge the patient. So now you know what is the copayment. Now remember, if someone has HMOs, usually do not pay. Medicaid, any of those plans under Medicaid, sometimes they don't have to pay anything. It's not that you're not paying, it's that it is the copayment, it is included within the capitation or the capitated fee. So that's basically what it is. Now, what happens if the patient do not have a copayment? Oh, I don't have a cash with me. Well, if you take credit cards, debit cards, well, you can suggest, payments to be done through those modalities or methods. Otherwise, you just tell your office manager, don't tell the patient, oh, we're not gonna see you because you're not giving us the copayment. No, because that copayment is gonna be billed to the patient. So if the patient doesn't pay the copayment, that copayment is gonna be added to the claim form plus the visit. So if it is $15, it's gonna be $15 copayment, $25, $50 copayment. This is like, like taxes kind of thing. You pay this much for your item now plus taxes. So that's what we're gonna do with the billing. So it's not that you're not paying, we're gonna add it to the bill. If the patient says, oh, I don't have the cash, I can pay next time, let the office manager about that. Because remember, if you register the patient, if you took care of the patient, you're gonna be responsible for that. They're gonna blame you if you don't have an answer. What happened to the copayment? Because some of the patients, most of the patient pays cash, they might think that you stole the money. So be careful. This is, it's very sensitive. So don't ignore the copayment, request for it, because that's part of the financials for the office. Okay. Covered person. So once again, it's like self-explanatory. Who is the covered person? It's the person who is the insured. Remember, I gave you those terms yesterday. So whenever you see this, because you don't know which term they're gonna use, someone who's covered, meaning have insurance, that individual is insured, have insurance, is the policy holder, have insurance, is an enrolled participant or patient. That's a covered person. Now, also, if you are a dependent under that benefit plan, you also are covered because you are covered for benefits. Your name is there. So that's basically what it is. So someone who has insurance, whether you're insurance, you are the policy holder, you are the insured, you are the enrolled, or whether you are dependent, you are under someone else insurance policy holder. So when you are the covered one, when you are the insured one, when you are the policy holder, then your name is gonna be there on that insurance. You are the primary policy holder. Other than that, you will be a dependent. So if you are dependent, when you fill out this claim form, both names needs to be there. Who is receiving the services? Who's the patient? Because the patient is not always the policy holder. No, it might be the dependent that is there. So for that reason, we have to mention both. Who's the patient who received the services? We put it right here. Patient, name, last name, blah, 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 all the information. And then policy holder. Oh, if the policyholder is the same as the patient, then you just write down the same. Other than that, you just have to write down the name of the policyholder. So that's how a covered person is. As long as you are under somebody else's insurance, you are covered. And if you have your own insurance, you're covered, whether because you pay for it or because you got it through your job or through the government. You are covered. Any questions about copayment and cover individuals? Okay, more terms that we use for these managed care organizations. Participating hospital. Now, when we talk about participating hospitals, are these hospitals contracted with this particular insurance company? That's called a participating hospital. If I'm enrolled in this particular insurance, I'm a participant, but to receive reimbursement. That's what it's talking about, not to receive benefits. So hospitals can contract with these HMOs. They do. So that's basically what it is. So they are called, participating hospitals or participating providers, which is the second one. Remember, we are talking about here which insurance companies the hospital have contracts with. Remember, hospitals, large organizations, particularly those organizations that are funded by the government, they take every single insurance. Any single insurance plan, they take it. You have to. You have no other options. If you receive money from the government, how is it that I'm paying you to run your business, but you're not accepting my plan? It would make no sense, right? So that's basically what it is. But hospitals, whether they are private, whether they are government funded, they take all the insurances, all of them. So that will be calling participating hospitals. You enroll, you have a contract with this insurance company. So therefore, you can take their clients. So I can accept Blue Cross, Blue Shield. I can accept United Healthcare. I can accept Oxford. I can accept any insurance, whether it's private or commercial, means the same, or government insurance. I can take Medicare, Medicaid, and all these plans or HMOs under Medicaid. So that will be a participating hospital. Participating provider. Now, this is a medical provider. Talking about the medical offices. This is, okay, let's go back to participating hospitals. The insurance company pay the hospital, not the providers, not the medical doctors for the services. No, they contract because it's the hospital that contracts with the insurance company. So the insurance company reimburses directly the hospital, and the hospital pay the provider, the medical doctors. So when I was working at the hospital, I get paid by the hospital, not by the insurance. Yes, I'm the one who saw the patient. I'm the one who got that procedure, diagnosis. I'm the one who, generate this super bill or encounter form, and I gave it to the billing department, and they bill, but they're not going to bill under my name or on my behalf. They're going to bill on behalf of the hospital because I'm an employee from the hospital. The hospital is not mine. We work for them. So that's what is called participating hospital. Now, participating provider is the other way around. If I have my own office, well, the insurance is going to bill me because I'm the owner. That's participating provider. So that's basically what it is. So that's what I want you to understand in very simple terms so you don't get confused. So a payer, what is a payer? An insurance company or a third-party administrator or the self-insured person. A payer is the one who's paying for the services. Well, an insurance company pays for the services of the insured clients. That's how it is. So that's basically what it is. Or the third-party administrator, which is the same. Or self-insured. If you have your own insurance, who's going to pay for your services? You. So that's basically what it is. So these are terms, that we're going to use every single time that, we are in the financial arena, because we need to understand, because some people do not understand. Before I joined the hospital, I thought that, they were going to reimburse me directly for the services. But then I said, I don't understand. Because if the hospital offered me this salary, I'm not gonna get money from them because I wasn't familiar with insurance. Because I knew some doctors and they were getting paid. So I said, oh, so if I work in a hospital, then I realized that it wasn't like that. That unless I have my own practice, I will not get reimbursed directly. But in order for me to provide services and get reimbursed, whether reimbursed directly to me or to the hospital, I have to have credentials. I have to have a license. In the place that I'm working has to be licensed as well. Remember, the organizations needs to be licensed. The providers needs to be licensed in order for us to legally get reimbursed for services. So that's basically how it works. This is the terminology that is used in insurance in general, not just for the managed care organizations, but insurance in general. Case management. So develops cost-effective patient care plans for difficult cases. So when someone has a case, let's say a open heart surgery, heart transplant, kidney transplant, this is not something that is done directly by the patient. It says, oh, you know what? I need a kidney transplant. And you go to your doctor, says, hey, get me a kidney transplant. I need one. My kidneys are not working fine. That's not how it works. This is going to go to a group of people who's called case management. And they're going to deal with the situation. That's why whenever you need these type of surgical procedures that are very complex, like organ transplant, you have to be in a waiting list. They start your case and they start trying to figure out whether there is an organ available for you. And we're talking about the entire country. They're going to review it. If it's not, they're going to put you in a waiting list. At the meantime, they're going to make arrangements for you to receive dialysis or other type of treatments as necessary. So this is when the group of people is going to study, your case and determine what is the best alternative or the best option for you. And the fastest one, of course, based on, availability, professional someone who is a professional in that particular field that can do the procedure if that's the case. So that's basically how it is. This is like, when you have, because this is very expensive. So that's the reason why these situations needs to be studied. It needs to be evaluated to see what is the best outcome for both the ones who are going to pay for the service and the person who's going to receive the services. So that's basically what it is. Case management. Second surgical opinion. Probably you heard about second opinion. Well, these managed care organizations require for certain procedures, certain evaluations to have a second opinion. So that's basically what it is. And the most important thing is not just getting the second opinion, it's getting paid for these evaluations. Because remember, if you have been sent for a second opinion to be evaluated by a specialist or another doctor in the same field, because you're not sure about whether this is exactly what the diagnosis they gave you is correct, or you have doubts, or you want just to make sure that there is other options besides the surgical procedure and you're going to discuss it with someone else. But you want the other person to order other tests that your actual doctor is not doing it. So once again, this is mandatory by the carrier, by the HMO, because they want to make sure that you get the best care possible. So if a second evaluation needs to be done, it should be done. But then we got to make sure that it gets paid. It gets reimbursed. So that's basically what it is. So when something goes beyond what was planned, when a surgical procedure or something else, or a diagnosis or a treatment requires something beyond what your insurance pays, we're going to use something that is called a modifier. So that's basically what it is. A modifier is 2 digits, just like the example that we have right here. Place 32 modifier for EM, which stands for evaluation and management. So remember, evaluation and management is the code that we use when you come to our office and you tell us what is the problem, and the medical doctor do all the evaluation, all the SOAP note. When we run through all these SOAP note, that is evaluation and management. It's the time that we spend with you during that visit. And that's what we charge for it. Remember, services is a totally different thing. So then we don't call it services in this case, we call it evaluation and management. Now, the procedures, that will be the CPT. And when I give you the diagnosis, I'm going to be using the ICD-MC. This is diagnosis codes. So that's a totally different thing. So we kind of, use the appropriate coding system for each one of the services that we provide to our patients, or for each one of the services patient receives, because we got to charge for everything that we do. This is not just one sum of money that we get paid for one thing. All the patient came here, we did blood, we did EKG, did a pap smear, and did some surgical, and we get just paid the amount of the money that we receive for the visit. No, that's not how it works. Each individual service, whether it's E and M, which is evaluation and management, CPT, which is the procedural diagnosis, ICD, CM, those are the things that we're going to do, plus others that will be included in coding. We're going to cover insurance, not coding. We will mention some of the things. So that's basically what it is. So remember, we're talking about health insurance. And when we talk about health insurance, it's how we are going to be reimbursed for the services provided to the patient. And if we're going to send an extra service, because with the same code, it's not going to be, we're not going to get paid, just going to get paid whatever it is for that particular code. But if I'm going to be paying extra, then we have to use these modifiers. And these modifiers, what they do, they represent whatever extra, what we went beyond what was needed, what was standard for the procedure of this patient. So that's basically how it is. So in order for us to get paid, we have to get this. Think about this. You go to the restaurant and you order, a standard dish, but then you want some extra order. Oh, by the way, can I have these extra French fries? Or can I have a sausage instead of this? They're going to charge you extra. It's not what actually the dish costs. That's what you see, but you ordered in something else, or you want something else instead. Certain items that comes within, your dish. So that's exactly what happened to the service. I spent 45 minutes with you, but then something came out. My patient fainted. I wasn't expecting the patient to faint, or the patient started convulsioning, or the patient have a heart attack right there in my office. That's not the reason why my patient came, but it developed something. Well, we're going to charge for that procedure that we're going to do, because that's not the reason that you were here. That went beyond what I was expecting I was going to have with you. If I said, oh no, we spent 45 minutes, an hour, but I don't mention, well, but I went beyond that. I spent like 2 hours, but wait a minute. We don't pay 2 hours for a physical exam. We pay after an hour. So what is that other hour came from? So we have to specify by adding a modifier. That's how it works. That's how the coding works. So again, this secondary surgical opinion is just something that is done because it's necessary due to the fact that, instead of spending money doing the procedure or not doing the procedure, or doing the procedure without an expert kind of evaluating the situation again. So that's important. Now we understand that most of the cases, serious cases, needs a second opinion. You don't get a second opinion just because you have a cough or because you have fever. That's not, oh, you got a diarrhea, oh, need a second opinion. No. Usually these situations are controlled easily by your PCP. Now you need to be evaluated by someone else. Oh, well, that's going to be extra. And we're going to make sure that, you receive the services because the other person also gets compensated for the services. Remember, the other person is going to do exactly what I did. They probably going to come out with something else. I've seen a lot of people who, they've been diagnosed with a condition and they said, I don't think that I have that. I don't know. I kind of not trusting this person, or the results, I'm not pretty sure. Maybe there was some errors. Oh, no, I need this to be corrected. I need to be evaluated by someone else. And that's fair enough. You should do that. And insurance is paid for that if merits that evaluation, that secondary opinion. So that's how it works. Any question about these second surgical opinions? Remember, this is mostly for surgical procedures, not once again, because you have the flu, because you have diarrhea. No, that's not something that qualifies for it. It's a surgical procedure. It's a serious, complex procedure where, the risk of the patient might be at stake, or too much money pay for this procedure, the probability is not going to be needed, or actually is needed, but your medical doctor doesn't want to order that. Then you get a second opinion. Gag clauses. Think about a gag order. So that's basically what it is. So what is a gag? A gag is an order that prevents someone from disclosing certain information. So that is basically what a gag is. But in insurance, these gag clauses means that, your provider cannot by no means explain to the patient, oh, I'm going to be getting paid this much if I do this treatment. We don't discuss that with the patients. We discuss with the patients the procedure. We discuss what's going to be, what are the risks, what are the benefits, what are other options the patient may have. But we don't talk about how much money are we getting reimbursed for doing this procedure. That's a gag disclose. Believe it or not, sometimes sounds like logic. It says, oh, who medical doctor is going to be discussing that? No, because sometimes, see, remember what I told you before? A medical doctor cannot tell you, oh, listen, I'm not going to provide those services because, that insurance that you have doesn't pay me much. So I'm not accepting you as my patient because your insurance doesn't pay. There's very little that pays for your services, so I don't want to take. That's actually illegal. So again, that's basically what a gag clause is. Even though if you don't have money to do the treatment, because that's one of your rights as a patient, I have to offer you. Let me give you an example. You have an insurance and you know that this insurance will not cover services for this particular procedure. You know it because we as medical doctors, we know certain services goes beyond what the insurance might cover. Then I said, oh, you know what? Oh, there is no treatments for you. There is no options. Or, these are the only options you have, taking this medication, doing this. You give them something because you said, I'm not going to tell them that, you have other options because then you're not going to be able to afford it. No, even though if you cannot afford it, even though knowingly that the insurance is not going to cover, you have to disclose that there are certain procedures for you out there. Now, let me give you an example of what these procedures are, how you actually can get those procedures, even though if you don't have money. So I don't know if now they have these websites or these applications, I don't know what it is actually, that is called GoFund, right? Well, sometimes you have a medical condition, they put it in the news, they publish it in social media, and someone out there decides to pay for your services. That can happen. So why are you kind of not giving me all the options? Yes, my insurance cannot pay. I don't have money for that. But hey, Someone else might do it. I've read, news about people that have very rare conditions, and there is very difficult to find treatments for them. And then suddenly someone from another country, a very knowledgeable medical provider, offers to do the surgical procedure for free. So that is one of the things that God closes, prohibits. Once again, prohibits from medical provider disclosing how much do we get paid for the services. And you should not deny the patient options just because of the fact that the patient might not have money to pay. So we have to offer everything. It's up to them. If they go to charity, the organization, or something else, and somebody gets the money and they can get the treatment. But if I have no options, what are you going to do? You block all the doors. You tell me that I don't have no options, but I do have. It's just that you're not revealing them because you think that I cannot afford it. Yes, actually, I cannot afford it. My insurance do not cover that. But someone else might do it. But if I don't have options, I'm not even going to say anything. I'm just going to stay quiet, right? So that is the God close. Any questions about these God close? Good. HMO models. So when we talk about models, we're going to talk about closed panel and open panel. So in general, what is a closed panel? We're going to discuss it in detail. It's in the next slide. Closed panel is when the HMO is in charge. So that's basically what it is. And we're going to talk about that. So directly, we are abide by the HMOs. Open panels, well, the opposite. We are not abide by the HMOs. So we're going to see. For the closed panel, we're going to have the group model and the staff model. So we're going to discuss those. And for the open panel, we're going to have the direct contract model and individual practice association and the network model. So we're going to talk about them so we can get a little understanding. You will not be asked about these closed or open panels, but it's a good thing that you understand what they mean. Who's paying, who is reimbursing directly? The medical providers or the hospital? Who is not abide by these HMOs? Who can charge, whatever they feel like they want to charge without having limitations? So that's important for the medical providers and for the hospitals, as well as for the patients. And somehow we are patients. Closed panel. The clinician is owned by the HMO carrier. Now, literally, does not imply that they own the medical providers. No. That means that this HMOs pays the medical providers. That's basically what it is. Because the providers are employees of the HMO. So the HMO is the one that, gets the money and reimburses the hospital. And the hospital pays the employees because that's how it works. That's how it works. So let's talk about these closed panel models, group model HMO, and the staff model. See? The HMO may contract with the provider who are part of an independent group of practice. So the HMO contracts with that group directly, not with the medical provider. In other words, remember, the group is responsible for reimbursing the provider who treat the patient. That's what it says. Then, the providers are owned by the HMO. So somehow, well, we don't get paid. Remember, we don't get paid directly for rendering the services. We get paid by the hospital or the organization, which is a group model because it's a large organization. So that's basically what it is. It's close. Why? Because I don't have the chance to get the money directly from the insurance company. I'm the one who provides the services to the patient. But I'm not the one who signed contract with the HMO. It was the hospital. So that's basically what it is. So I get paid by the hospital, not by the insurance directly. So I'm an employee. So when you work, wherever you work, you are a closed panel model, so to speak, because you get paid by your employer, not by the person that you render the services, whatever you were doing. See, I work for a closed panel model as a teacher. Why? You guys don't pay me for teaching you. You pay the director, you pay the school, and the school pays me. That's how it works with the medical providers. So I hope this was clear enough. Staff models, HMOs. The providers are employees of the HMO. All premiums are paid to the HMO. It's almost the same as the group, but this is a staff model. So the providers are pay employees. Again, they are employees of the HMO. So all premiums are paid by the HMO. Remember, premiums means this in this time is the money that you pay for your insurance for each one of them. I pay my premium for my insurance, my car insurance. So it is the total amount of money that I pay for car insurance per year. So that's basically what it is. I'm a health insurance through a institution, so up through a group. So that's basically what it is. Now, you shouldn't be worried about this, but that's how it works. Now, think about the opposite, open panel HMOs. The healthcare providers are not employees of the HMO and do not belong to a medical group owned or managed by the HMOs. So you work for a private company, for a private insurance. Because remember, HMOs can be private organizations that they just contract with them because it's convenient. So you see, United Healthcare, it was a private insurance. Now it is private, but it also is part of the HMO. So you can get services privately and you can get services through an HMO. Why? Because it is convenient. Remember, you contract with these people, they give you better rates, better premium for your employees. So therefore, they give you cheaper prices, premium for your employees because you have a bunch of them. Oh, I'm going to give you 100 of my employees. Okay, how much are you going to charge me all together for insurance per year? Oh, because you are giving me all these people, I'm going to give you a discount. Now, these are the HMOs, but the private insurances, they don't care about that. They don't care that you give me 100, 300. Oh, no. It's individual. I charge you individually. It's not quantity. It's quality. So that is open. So it is the opposite. So we do not deal directly with the HMOs. So you have the freedom of charging more money for your services. Why? Because you pay a higher premium and you are not abide by these HMOs. Remember, the HMOs has to do with money from the government. Well, not exactly the government, but from the taxpayers. So they have to abide by the government laws and regulations. You have to render services for a cheaper price versus private commercial companies. They don't have to do that. Why? Because it's their own money. They are investing their own money. That's their own businesses. So they charge whatever they feel. This is business. So that is an open panel HMO. So we have three models of open panel HMOs. Now, again, this is part of the curriculum, not that you will be asked, but it's for you to understand how the medical doctors, the hospitals, the organizations get reimbursed. Why some of them, get paid, you as an insured pay less for insurance or pay nothing versus other premiums, other insurances are so expensive. Why is it that I need a referral? Why is it that I need the pre-approval and others do not? What is it that I have to have a gatekeeper, a person, a PCP medical provider that I have to go to this person always if I need something before I go someone else? I have to see this person first, and this person is going to decide, my primary care physician, where I'm going to go next. And this doctor decides that, there is no referral, so nothing else, then, we're going to treat you and they're not going to send you anywhere else. It's their decision, so you're not going anywhere. Versus if you have your own insurance, a PPO, POS, that is not a managed care, then you can go wherever you go, what you want to go. You can decide which medical provider you want to see. You don't have to go see one, and then that one has to decide whether you're going to move to the next one or not. That doesn't work that way. So that is like closed and open. Open, you had the freedom to choose who you want. Closed, you had to see only people from this network. That's basically what it is. And you had to accept, what is the, what services you can receive. The assignment of benefits. The direct contact model. Now, remember, these are open panel HMO. Individual physicians in the community provide contracted healthcare services to our subscribers. So now, that's it. This is a medical doctor. You open your own office, and I can receive the insurance if I want to from any of the subscribers. It might be an HMO, but in this case, we're talking about the HMOs. So I can receive insurances, but I'm not obliged to. But if I am an HMO, I'm obliged. If I'm a close, I'm obliged to. Here is if I want to. Remember, the medical doctor's offices, in order for you to reach any medical facility, in order for them to accept this particular medical insurance from patients, they have to contract with the medical insurance first. It's not like, oh, I have this medical insurance from Florida, and I come here and they don't have the medical insurance. These doctors are not going to receive it. It says, oh, what is the insurance from? I don't know. I don't know it. I didn't sign with them. So I'm not going to get reimbursed. They don't know me. How can you get services, internet services from a company that you didn't sign up for? You don't. It doesn't happen. You're not going to get phone service from a company that you did not have a plan with. That's not how it works. You sign up with this particular company to get your internet service or cable services, and that's the one that you're going to pay the services, right? You're not going to go and say, oh, I'm going to use another company because I just heard about other companies, so I'm just going to enter, and no, you're not going to have service and you're not going to be using it. You have to sign a contract with this particular managed care or insurance companies. Every single medical facility sign contracts. Is not automatically. This is not like I open a store and anyone can come and buy. Because remember, they are buying whatever I sell, my items, but this is not an insurance organization. This is not a medical facility where I have to get reimbursed for the services that I provide. If it is cash, that is fine. You see, some of the stores, they don't take debit or credit cards. They take only cash. That's their policies. So the same goes with these particular contractors. If I don't want to sign up with HMOs, I just don't sign up with HMOs if I'm the owner of my medical office. I just get commercial only because it pay me more. Nobody's going to oblige me to do. But then I'm going to miss out on some of the clients. Even though if they're going to pay me cheap, still, I'm going to compensate for the ones that I don't get in commercial. So I get little here, but I have more right here. So that makes the whole thing work. So that's basically what it is. So remember, these are, directly the individual physicians and the community, remember, provide the contracted healthcare services to subscribers. So I open my door for this particular insurance if I want to receive them. That's basically what it is. Individual practice associations, very similar to the other one, but there is a little difference right there. So it's the same as the individual practice association. Now, remember, association means that it's not one doctor. We have 3-4 doctors within that little office. So that is an association. So each one of these providers might contract, or me as the owner of the office, I contract and then I pay you. But most of them, they contract independently. So that's what it is. So the difference is that this individual practice association can negotiate contracts and manage the capitation payment from the HMO. So here is when, remember, these HMOs, they have a capitation, a fixed rate for services for every single doctor, regardless of where we are located. So I mentioned it before. If for an EKG, I pay $50 as an HMO, everyone who has my insurance is going to get paid $50. If you want to be taking patients from my insurance, I pay $50 for an EKG. That's it. I'm not going to pay no more. So that's basic. But sometimes the medical providers can negotiate with the HMO. I said, listen, $50 is not convenient for me. So what about $60? If you give me $60 for EKG, you give me this much for the blood, you give me this much for the I will take your insurance. So they can negotiate sometimes. And they do. My friend does. That's what I know this a lot. Because I'm familiar with that. So, I'm being through all of these things, so they can negotiate. And they give you a little more. So if the capitation pay $30 or $27, they're going to say, oh, can I get 30? for each patient, and then we are in business. We can sign a contract, so I can take all your patients from your insurance. Remember, this is convenient for both the insurance company and the medical provider. The medical provider is going to receive not much money, but it's going to receive patients. And the insurance company is going to have you, that you are going to provide, insurance services for their clients. So that's how it works. It's a little kind of, complex, but again, it's just, these models is more likely of who pays and how much they reimburse the medical provider or the hospital. That's basically what it is. Network model. So contracted services are provided by more than one provider group or practice. So that's basically what it is. So it is a network. So it is different insurances that you can access. They are HMOs. See, some people have Medicaid and Medicare at the same time. Remember, we're talking about HMOs. So basically, or you can have Advantage as part of Medicare. Or you can have a private insurance and Medicaid. So that's basically what it is. Remember that I mentioned that I might say back in the days, like 20 years ago or so, the Medicare was plain Medicaid. There was no MetroPlus, Fidelis, none of those. There were no HMOs. It was just Medicaid. And Medicaid was paying really good back in the days. Now things have changed. See, Medicare is still plain Medicare, but Medicaid have all these HMOs. So that's basically. So those are the things that we need to understand, that the HMOs are, these insurance companies that, or a managed care organization that has all these insurances within that kind of, limit the services that the patients can access. To the purpose was to cut down the cost of the price of the services. Because remember, I mentioned it before, medical providers were kind of, ordering everything that it could possibly think to diagnose the patient instead of doing what they're supposed to do, all the physical exam, all the procedures, and then, order expensive tests if they were needed. But if it's not needed, now you don't receive it, you don't get it, you not be approved for it. And they have capitation. So they have a fixed rate that they pay the medical doctors. Remember, Medicaid, with all these HMOs under, like the ones that I mentioned, I used to know most of those, but kind of not used to much the insurances. I just remember Fidelis, MetroPlus, HealthPlus, something else, and United Healthcare. Those are, capitated. Remember, they pay for each client, for each patient, $30 per month. Whether you go 30 times per month or you go once or none, you're going to get paid $30. We are talking about just the E&B. Remember, the evaluation and management, just for the visit. Oh, I have a headache. Okay, I'm going to evaluate you. I'm going to determine what you have. That's it. And then for the medications, this HMO is going to reimburse the pharmacy because the medications do not belong. We don't dispense medications in a doctor's office. Then the managed care is going to pay the pharmacy. So the pharmacy is going to contract with them, just like medical providers do. Pharmacies do not get paid to the medical providers. No, they get paid individually. If I have my pharmacy, the insurance company is going to pay me directly for the medication that I'm dispensing for these particular patients, regardless who prescribed them. It's like, you go to the store, you buy something, you got milk, you got orange juice, you got potatoes, you got chicken. Oh, you pay for them. You pay them to the store. You're not going to be paying to, to the farm where they get all these things. So that's basically it. So that's basically how it works. All these models are important for reimbursement, remember, because this is insurance. Accreditation. We talk about accreditation. Remember, this is a monitoring or a voluntary process that is done to every organization, medical organization. We're talking about these organizations that are funded by the government and usually are the big corporations like hospitals, nursing homes, hospice, all those places. If you receive money from the government to run your business, then you need to go through this process of accreditation. Doctors' offices do not go through this. If you are a private organization, you're not receiving money from the government, you do not get, you don't get these evaluations from the Joint Commission. So that's basically what it is. And it is voluntary. They're not going to force you, but they're going to do it anyways. And they're going to show unannounced. They're not going to tell you, hey, we're going to be there this day. Why? Because if they tell you that they're going to come, then you're going to straighten all your stuff, right? No, they're not going to tell you. They're just going to show up and they said, okay, we are here to evaluate you. Pull this medical record, pull that one. Randomly, they select. Call medical personnel and start interviewing them, asking questions. So this happens every 3 to 5 years in a hospital. So if you work in a hospital, be prepared for that. Sometimes the hospital knows ahead of hand. They said and announced, but they will eventually know. So that's basically what it is, because you have to meet certain requirements in order for you to stay in business. So you have to be accredited. Schools has to be accredited. Every single organization, restaurants has to be accredited. So you have to have license to function. So that's basically what it is. So the accreditation has to do with everything from the physical building, the facility, and the credentialing of everyone who works there. Now, whatever you're going to do is because you have that certificate, that training, that license to practice, whatever you were trained. And these licenses needs to be active. So that's basically how they do. For the well-being of the patients, just for quality care. That's the accreditation. So quality assurance, remember, these are, the concepts that, these accreditation bodies have to protect, the well-being of the patients. So they got to make sure that they meet all these requirements. So which organizations are involved with, accreditation and quality of care in the workplace? First of all, is the government, of course. And how do we know? Because we're going to receive all these patient satisfaction surveys. Remember, every single organization, whether it's medical or not, they have these satisfaction, surveys that they ask you to fill out some forms. This is like, certain organizations, when you receive service, they ask you to complete a, survey to say how the service was provided. So the same goes for the patients. The patients can go to the website and, for that particular organization and fill out one of these surveys. And if you weren't satisfied because you're going to give me a grade about it, then, this service are going to go to the hospital committee of ethics. They're going to go to the government and certain organizations like the Joint Commission, the National Committee for Quality Assurance, and so on and so forth. So again, it's not going to stay right there. If somebody complains about something, if somebody, during the survey they mention something, so then it's going to be investigated. Because they're going to be anonymous, that's going to be an anonymous survey. But they're going to investigate because the organization that provides the services is not anonymous. It's anonymous who provide the survey, not the services to the patient who is complaining or, filling out this survey. So that's basically what it is. So that's important. So your voice is heard. So if you complain about something, if you fill out a survey, sometimes it's a good thing. Sometimes nobody does anything. So it is, relative. It might not work. The patient bill of rights. So before we start with the patient bill of rights, we're gonna take a break and we're gonna get a little rest. And when we come back, we're gonna continue. We know some of the patient bill of rights, but we're gonna add some others for the purpose of the medical insurance and for the purpose of reminding you, refreshing your mind about the patient's rights, because it's very important that we understand what rights do we have as patients, and those rights should be honored every single time that we receive services, regardless of where the services are provided. So let's take once again 30 minutes break. We come back 7:30, and then we continue with this chapter. We're almost done with this, and then we are going to start another chapter. All right. See you in a bit. 7:30 it is. See you later then.
Okay, thank you.
You're welcome. Enjoy it. Okay, so we are back. I hope you guys enjoy your break. Let's continue with this chapter, almost done. So let's talk about the patient's bill of rights. Remember that is something that always comes in exams as well. So if we have to kind of go over and over and over and review the same stuff and add something else, we're gonna do it, right? So for the purpose of the insurance, information disclosure, remember, we're gonna talk about HIPAA, we're gonna talk about privacy, we're gonna talk about confidentiality, we're gonna talk about security. So that is basically all the rules for protecting the patient's information. Remember, we are dealing with the patient information here that we are disclosing to the insurance company for necessary purposes. So again, this information needs to be disclosed only for the purpose of reimbursement. So that's basically what you need to understand. So right to accurate and easily understood information. So the information that you enter in these medical forms or claims needs to be clear. Again, now everything is done in computer, so it's gonna be typed. So we're not gonna have any problems not understanding. But the problem is that we might be misspelling or using different terms that might sound alike, might look alike, but it's not. So we gotta make sure that all the information is accurate so we can get reimbursed immediately instead of receiving these claims and have to review them and resend them again because that's going to delay the processing of the payment. So the reimbursement is going to take longer. So choice of providers and plans. Now, the patient have the rights to choose whoever they decide they want to receive services from. So that's basically what it is. You're going to choose which hospital you're going to go to, which medical providers from these medical hospitals or specialties, or a independent medical provider you want to see. Remember, that's your choice. Sometimes, these managed care organizations, they assign you someone, but they assign you someone when you do not select that person. But it's your right. If you want to change them, you're going to switch them for any reason, you just have to have a, motive why you want to switch this doctor and how often can you switch these doctors because these HMOs have lots of limitations. But going back to the patient's rights, yeah, you have the right to select who you want to be, who you want to medical provider to be for you. Remember, most of the time we select who do we want to have as a PCP or as a medical provider. Access to emergency services. So regardless, emergency, I mention it again, emergency are one of those situations or places that do not follow many regulations. We try to comply with HIPAA, with OSHA, with all these regulations, but unfortunately, due to the situation, to the complexity of the situation of the patient, sometimes we have to waive certain rights and, try to do the best for our client or patient. So that's basically how it works. Now, in an emergency situation, whether it's actually an emergency or not, we should not deny services for any reason. A medical doctor, an ambulatory services, a surgical procedure that has been planned ahead. all these services, you can deny services to the patient. But an emergency, it is not. You cannot deny services to a patient in an emergency room, regardless of what they have. You have to take care of them. Even though if it sounds like it's not important, it is not an emergency. Remember, services in the emergency, people use the emergency as their primary doctors. They go for anything. That's not a place for that. Remember, emergency is for someone whose life is on stake. If it's not at stake, then it's not an emergency. But we do not use the emergency sometimes for that purposes. We use it for any reason. But regardless of what is the reason that you show up to the emergency, you must receive attention for that visit, regardless. Whether we have insurance or not, whether we are legal people in this country or not. So nothing stops the patient from receiving healthcare in an emergency. Remember, in any other circumstances, medical providers can deny treatment. Remember, you have to contract with your medical doctor, but in an emergency situation, we don't contract with anyone. We waive all those rights, and then when the patient is stabilized or the patient recovers, then we can get access to the information, to the billing, personal information, or the patient can pay, cash if they don't have insurance coverage. Or as many of the people who go to the emergency, they never pay. So again, this is one of the things that protects the patient's rights. Because in an emergency situation, remember, things are unforeseen. So it's a very, very important part of the medical services. So that's basically what it is. So you don't need a prior authorization, you don't need a referral, you don't need anything. You don't even need to have an insurance card, nothing. You just take care of you, and later on, we deal with that. Later on, you're gonna be billed at home or bill somehow, make arrangements for payments. But at the meantime, at the time being, they're gonna be taken care of. That's patient's bill of rights. So remember, whenever you have questions on your exam about emergency situations, many of the things that we kind of, follow policies, regulations within a regular, doctor's office and ambulatory or hospital specialty, we do not follow much those things because it is a different situation. Participation in treatment decision. Well, regardless wherever you are receiving your services, from who you're receiving your services, you gotta be part. You are part as a patient for the decision, for any decision that the medical doctor wants to, decide for you. So you gotta be part of it. You decide whether you want to go with the treatment or whether there are other options. So you determine if you want the services or not. Remember, that's the patient right. Remember, the patient has the right to refuse treatment. The patient needs to know what type of treatments you are going to offer to the patient. What is it? What are the advantages? What are the disadvantages? What are the side effects? So you have to inform the patient. This is like doing a procedure. I'm going to order this particular treatment. This treatment, you have to explain the treatment. What is it? And what is the reason that I'm ordering that treatment? What I'm planning to find out, or why? What am I giving you this test? So that is participation in the treatment decision. Whatever, relates to the patient's condition, we got to make the patient participant. And not sometimes the patient, the family members as well. So again, very important. Non-discrimination. Well, that's unfortunately personal. That depends of each of the medical providers, but you should be free of discrimination based on all the things that I've been mentioning before. Race, gender, sexual orientation, religion, mental or physical disabilities. None of those things. Your nationality, oh, you're from this country, you are from, none of those should be considered issues for denying services or delaying your services. Again, that's the most important thing. Always to, treat you as an individual, as anyone else. Remember, always have empathy, compassion. That's what we need. It's just for the purpose of the treatment. This is not a person that we are going to be having a relation as a friend or something else. No, this is patient medical provider relationship. You are here because you need problems to be solved, and we're going to try to do our best to solve your problem. So treat it with respect, with dignity. That's what we deserve as a human beings. You're going to use the best of your knowledge to try to fix whatever problems I have, if there is anything that can be done. You don't have to go the extra mile, going and do something that you don't know if it's going to work or not. Has to be scientifically proven, because there are precedents about treating these same conditions. So in the same fashion, you're going to give me the same opportunity to be treated. So that's basically what it is. Very important, patients bill of rights. Confidentiality. Remember, we talk about this. Keep the patient's information, confidential, not releasing it to someone else without the patient's permission. Unless it is one of our associates, then it's a different issue. Remember, associates are the people who are dealing with your care at the same time. We can be asking you all the time to sign a release of information for billing. Oh no, that was part of the contract. When you sign up for, to become our client of our office or patient, when you have this patient relationship established, that's one of the requirements. And you're going to be informed. And also you're going to be liable for, responsible, let's put it this way, for payments if the insurance does not cover or do not cover everything or part of it. You will be responsible for any of the balances or the whole thing if the insurance doesn't pay. That's basically what it is. So your health information should be protected at all times. So whether it's paper-based, whether it's computerized, whether it's on the fax machine, whether it's over the phone conversations, we have to keep an eye on that, to keep confidentiality, privacy, and security for everything that it is in the computer system. So that's basically what it is. And if you have complaints, we have to listen to those complaints. Try to fix it. Try to make sure that this is not going to incur in a lawsuit. So that's basically how it works. To not ignore patient complaints that can actually lead to a lawsuit. So patients do not complain sometimes because they just want to complain. It's because sometimes things are not handled correctly. But if you don't mention it, or if you mention it, it's not corrected, things is just gonna get worse. So that's basically what it is. Now, once again, we're not talking about here healthcare in general. It's just for the insurance purposes, how we keep the patient's information. But in reality, the patient has some obligations as well, some responsibilities, which we discussed previously in other chapters. Okay, so we're done with this chapter. We're gonna move to the next one. Any questions before we move to the next chapter? Okay. Let's see. Okay, so this is the next chapter. This is legal and regulatory issues. Now, this is all about, handling patients' information. During medical insurance, this is for the insurance specialist. Remember, everything that we're talking about has to do, it is related to health insurance. Okay. So let's see, guidelines and regulations. We have a bunch of regulations, guidelines, policies, state and federal laws that protects, right? The rights of the patient, the rights of the insurance companies, the rights of the medical providers. So the law is there to protect us in general, not just to protect the patient. No, it protects everyone, because whoever is at fault is responsible, is liable for whatever, mishandlings of the patient's information have been done. So that basically how it is. Okay, so the healthcare insurance specialist must know about the different guidelines, regulations for maintaining patient records and processing health insurance claims. Now, remember that in order for you to complete these claims for, reimbursement, which is the form that we're going to send to the insurance company to claim for reimbursement, to be reimbursed, you have to get the information from the patient's medical record. Remember that the billing department is an associate to the medical, to the health system, because this is the financial part. Now that will be billing. It's not insurance, but insurance of the third party payer is also an associate to the medical care, because it's the one that is paying for those services. So remember, we have the first party, the patient, the second party, the medical doctor, the third party, whoever is going to pay, which is the insurance company. And if we are going to be involved in the insurance process, then we need to keep all these regulations and guidelines, on top, to make sure that we're not going to violate any of these rules and regulations when we're completing those forms. So that's basically what it is. Particularly, we're going to keep these regulations. I mean, we have to keep regulations in general for every single patient, regardless of what insurance they have, because that is the law, that is HIPAA. privacy, confidentiality, and safety. All these rules. Remember, rules means, law. These are, mandated. This is not optional. It's not voluntary. But for insurance purposes, we focus more on organizations that or insurances that pays for governmental insurances that that uses funds from the government or from the taxpayers versus from the private or commercial insurances. All of them has to follow regulations, of course. Fraud happens anywhere, whether it's private, whether it's governmental. But the government is going to be more stringent when it comes to fraud and other type of violations that we're going to see later on in this chapter. Something that you might think, oh, wow, I did not know that that was a violation of these, regulations for insurance. Yes, they are. Still, they practice this, but it is illegal, but they still do it. We will see what is it that we're talking about. So when we deal with this, remember governmental organizations or insurances, programs like Medicare, Medicaid, TRICARE, and these federal employees health benefits plans, we have to be very careful because we have lots of agencies that are keeping their eyes on all these claims and all these payments and all these codes that we use. Because there are many ways to try to utilize these codes to get a better rate or to get reimbursed more or higher than was expected. So that's basically what it is. So it's very important to understand that it's not just a federal level, meaning a national level, but it's also state-wide level. So state have its own regulations. So they are very close to us because they are here in the state. Every single state have their own rules and regulations and how to deal with all these claims and reimbursement and coding and billing and all the stuff. So that's basically what it is. So it's very important, not only for, regular insurances for medical health, but for insurance that has to do with workers' compensation plans. The workers' compensation we will deal later on, but just to give you a little advance, workers' compensation means, when you are injured on the job. So then your employer has to pay for the services for the time that you're not going to be able to work. So they're going to pay you your wages. They're going to pay you for medical services, anything that is needed until you return back to work, or they're going to give you disability services or benefits because you're not able to come back to work if you're still alive. If you die, then they're going to compensate your family for the loss. All that has to do with regulations. Remember, workers' compensation is a totally different way of handling these cases. They are not handled directly by your medical provider. This is by someone else who is adjudicated by your insurance company. It's not who you wish to go see. It's who your insurance company asks you to go see or your employer asks you to go see because they are paying for your insurance. Because this was, remember, workers' compensation has to do with injuries in the job. If something happened to you where you're working, you get injured, then now your insurance, not your personal insurance, that's not the one that's going to pay for your services. It's going to be the employer's insurance. the company for the one that you work, they have special insurance that is called workers' compensation. And that's the one that's going to pay for your wages, it's going to pay for the time off, it's going to pay for all the services required for you treatment. That's basically what it is. And not only that, we don't use the personal medical records to record every information about injury on the job. We have to open a different medical records. Think about an emergency situation. Think about when you are admitted. We have to open a different medical record for you. Every single time that you come to the emergency, we're going to have a different medical record. Every time that you are admitted to a hospital, we're going to open a different medical record, like, you were a new patient, kind of thing. So workers' compensation is exactly the same. If you've been injured in your job, we have to open a new medical record. And it's not your medical provider. It has to be a medical provider that accepts workers' compensation cases. And the medical provider that your insurance or your employer send you to is not someone that you want to. You don't choose who you want to see. They choose that for you. They assign you a medical provider for the workers' compensation situation. Again, it's not your insurance, your health insurance that pays for these services. It's going to be the company workers' compensation insurance that they have in place. Because by law, by these regulations, the company where you work has to have a workers' compensation insurance. Even though if they don't offer you, they don't give you medical insurance, they must have workers' compensation. So that's basically what it is. So it's very interesting and important that you understand, how regulations are, because you work. And if something happens in your workplace, you have to notify immediately your supervisor, someone who is above you, of the incident or the injury. It doesn't matter how lightly you might think it is. Certain things do not show immediately. Let me tell you what happened to one of my co-workers. He was working in this particular place. He fell down from some area that he was doing some work. He got up and he said, "No, I'm fine. I don't feel anything. I'm fine." 3 months later, he developed a headache. He went to the doctor, but then it was a very bad headache. He went to the doctor, they gave them some pills, like usual, right? For the headache. Then they asked him later on, because he continued with the pain, and he says, "No, these medications are not doing any good." So he started missing days for work because it was really bad, the headache. So he went back to this time to the emergency. They did a CAT scan. He has a tumor in the brain because when he fell, he hit his head. He didn't feel anything at that time because it was very mild, but started getting worse and worse and worse inside his brain. Just to make the story short, he died. 6 So again, it sounds like it wasn't a big deal, but it was true. It happens also to one of these famous, what was that? Skater or someone within sports. She also fell when she was skating, something like that. Something like that happened. That was like 5 years ago. She didn't pay attention to that. Say, "Oh no, I'm fine." Then she got a tumor in her brain. Then she died. Anything that happens to your head. Some people get injured in the back. Now you're not able to lift things, to do things. You can barely walk. And that doesn't happen immediately because you don't have fractures, you have other type of injuries. So you have to report them. Anything that happens to you has to be reported, documented. If something later on happens when you go to the medical doctor, they're gonna ask you, have you had any injuries? Recall what have happened before. Actually, I did fall, but I didn't think it was serious. Do you notify someone? Yes, I notify my supervisor. It's documented. You have to fill out an incident report. Because now if there are complications, your company is going to be responsible for it. But if you did not report it, you did not document it, or you didn't tell your supervisor, not just telling, hey, I was doing this and I just fall. Just keep it in mind, just in case, something happened later. Or no, that's not how it works. You have to ask for an incident report and fill it out and sign it and make sure that the supervisor sign it and you make a copy of that report and you keep it just in case later on. Because that will be like, your salvation tape. Other than that, something happens later on. And always tell all the people, even though that doesn't work sometimes. But it's good to communicate. Listen, I just fall. Listen, I just happened this to me. But the most important thing is report it to your supervisor, file a incident report, keep a copy of those. Don't just do it and leave it there because they can disappear, these documents. So those are the things that I'm telling you because remember, I was a medical provider and I know how those things works. So when it comes to lawsuits and things like that for malpractice or for workers' compensation, they always try to trick you because they don't want to pay, right? So that's basically what it is. But if you have everything documented, you're going to be on the safe side. So that's basically what it is. So we will discuss more about workers' compensation later. We're just talking about all these regulations that apply for reimbursement purposes because we're going to be using the patient's information. And remember, the patient information has to be kept confidential, private, secure. Let's talk about Medicare administrative contractors. So think about the word contractors. What's contractor? Someone who, has some type of specialty and they know how to do certain things or certain jobs and, you're going to contract with them. So Medicare administrative contractors are those. So these are insurance companies or organizations that contracts with Medicare, but particularly with the Centers for Medicare and Medicaid Services, CMS. You need to know what is CMS, Centers for Medicare and Medicaid Services, because these are the organizations that, have to do with reimbursement, payments, for the government. That's why we have the CMS 1500 format, which is the claim, the most common claim for reimbursement. So they are the one who decides how to process these charges, these services, which we are going to start calling them fee for service. And then we know exactly how we are going to determine how much they are going to be paying the providers for certain services. We will discuss about Medicaid, Medicare, because these are very, very important insurances. And somehow, one way or another, we are going to be part of it. Because remember, Medicare is for people older than 65. You're going to get Medicare after you reach your 65 years old. of age. Medicaid applies for any individual at any age. The only difference is like you have to have low income or no income. So back in the days, they used these terms that are a little diminishing or belittling, which, oh, this is for poor people and this is for the elderly, right? Well, I don't like to use those terms. It says for low income or no income. You're not receiving income. You qualify to have, Medicaid. If you are over 65, you are qualified for Medicaid. So remember that because that we're going to have chapter just exclusively for Medicaid, Medicare. So you can better understand these insurances because these are the government insurances that we need to be familiar with. Now, Medicare has part A, B, C, and D. For now, just for the purpose of the Medicare administrator contractors, we're going to talk about parts A and B. What is part A? Part A covers benefits when you are hospitalized. If you are admitted in a hospital, Part A covers for those services. What about Part B? Part B covers for ambulatory services. So that's basically what it is. If you have a relative that, is 65 and older, check their insurance if they have Medicare, and it's going to say there, Part B, Part A. And then they have another extra insurance, which is Part D for medications. If they have Part C, sometimes it's a supplemental insurance. So that will be discussed later on. But for now, remember, the Centers for Medicare and Medicaid Services, they are the ones who are going to determine how much money the medical provider is going to receive for these particular services, whether the patient is admitted, is hospitalized, or the patient is receiving services in an outpatient setting. So that's basically what is saying right here. Federal laws and events that affect healthcare. So there are many things that affect healthcare, but there is nothing like fraud. Remember, fraud is very, very common in medical. Hospital has been closed, medical offices has been closed, medical doctors have been lost their license and sued, and a lot of stuff. So let's talk about this False Claim Act. Remember, the word implies, see, the title tells you what it is. False claim. So you are giving false information to the insurance company. The false information means you didn't provide those services, but you're charging for it. The services were not like that, but you misfile those codes. So you use different code to increase the rate of money to get paid, or you use many codes with low profile. You down code, because if you up code, you think that you're gonna be caught. So it says, oh, no, I'm not gonna be charging too much for that. So I'm gonna be charging little, but different times. So I'm not gonna get caught because I'm charging very little, but different times instead of charging once and very large amount, because they're gonna investigate you. Why is this all this amount of money for one service? Wait a minute, we need to check it out. But if you kind of use different services for the less money, but if you add them up, it's gonna be just like one that you charge more. So that's basically what it is. So this federal law imposes liability. Remember, that means it's a tort. It's a violation. You are responsible. You are liable. for defrauding the government. Remember, they are very stringent when it comes to organizations that are funded by the government. That's why we don't play with the IRS. We don't play with Medicaid, with Medicare. Don't. Because sooner or later, if you get caught, you're going to pay the consequences. And that's not going to be fun, believe me. So I'm telling you, I know many offices, hospitals that were closed due to fraud. Not, bueno, yeah, it was like 2010, 11, something like that. In the 2011, something like that, it happens that they closed like a bunch of hospitals here in New York. I'm talking New York alone. I'm not talking about any other areas because I'm familiar with New York. But there were other hospitals because they were, found guilty of, fraud. That's basically what it is. And there are different types of fraud, not just billing for services that were not provided or increasing the cost just to get paid more. Not just that. We're going to see some other ways of committing fraud. You will see. So that's basically what it is. So what happens if you get caught, defrauding the government? As a medical provider, you lose your license. As a hospital, you no longer can receive, patients from these organizations, these insurance companies. And if you don't receive, if you don't have these clients, you're going to go bankruptcy. Because these are the insurance from the government, and this is the one that has lots of, clients. So it's not going to be good for the hospital. Or the hospital is going to lose, the funding that they receive. So they're going to have to close because that's the money that they receive. So first, they're going to find who is the perpetrator, who's the criminal, who committed the crimes. And if more than one person is involved, if they had, the higher management on the chain of command are involved, well, they're just going to close the business altogether. On top of that, they're going to lose their licenses as well. So yeah, it's not like, oh, well, we're not going to render services to you because you did something wrong to us. No, it has serious consequences. So that is the False Claim Act. So it's very important that we understand all these because, fraud in the medical field is very serious. It might not be so serious on the civilian world because, you pay an attorney and they can let you free. But with the government, it's a little different. Let's talk about the Food and Drug Administration. So now you heard about the Food and Drug Administration Act. So this is the Food, Drug, and Cosmetics. I don't know what it's not there, but it's supposed to be cosmetics as well. You see that every single product in the supermarket and pharmacies that have the FDA approval. What it means is that they follow certain regulations. They meet certain criteria. Because these are products that are going to be ingested that can cause, some conditions to the patient. The food is not just a natural product, but they have chemicals within, particularly these processed food. And most of the products that we have are processed. So they have to meet certain requirements. And when you read the labels, you're going to be seeing they are FDA approved. They have an expiration date. They have all the information about what is contained within that particular package or container. It has to have it. Same with medications. See, when they say drugs, actually, I don't like the word drugs. I like to use medication, but that's basically how it is, drugs. And that's what it is. Because every time you talk about drugs, people think that you're talking about illegal drugs, because that's how it sounds like. So again, this is a federal uh, regulation. Remember, they monitor the purity of the foods and the safety of the medications. When we get to pharmacology, I'm gonna tell you how these pharmaceutical companies um manufacture these medications, what regulations, what guidelines they have to follow, what policies. Is very stringent. It's not simple. And it's a lot of money invested doing that. Why? Because we care about the health of the consumers. So that's basically what it is. Once again, it also includes all what it is cosmetics. Those are things that you apply to your skin, to your eyes, to your ears, and they can cause also medical conditions. So it has to be FDA approved. And if it is FDA approved and you prescribe me that medication, I develop something, you're going to be responsible for it. If it's not FDA approved, nobody's going to be responsible for it because you take that under your own, responsibility. That's why you have to read the labels. That's why you can just be buying things that are not FDA approved. They are not responsible for it. Many people buy stuff online. It might be medication. They are medications for another country. The medications that are here is not the same as the one in other countries. They're different. There are different processing. Oh my goodness, almost get this. Almost shut down my computer. Almost forgot to charge it. So I'm safe right now because now the little, changes that I did are now I'm getting a notification. So that's how it goes with the Drug Food Administration. See, they have to meet these requirements. Everything has to be noted right there, part on the label and an insert that the product might have. And so you have to read it and you have to follow it. So we can find responsibles, or we can make responsible or liable someone because it was approved by the FDA. So remember, everything that is approved by the FDA doesn't mean that it's going to stay like that. If this product causes side effects or some type of medical conditions frequently to many people, they're going to review that product, that medication, and they're going to pull it off the market. So that's basically what it is. That's why when you hear all those things about recall, they recall this medication, they recall this type of product that from this particular company because it was contaminated with some type of microorganisms that is causing certain diseases to some people in certain areas. Well, we got to remove it from the shelves, or we got to remove, the medications from the pharmacy. So that's basically how it works. So it's very important that we understand that, we have regulations for everything. Okay, this is interesting. This is called the Federal Anti-Kickback Law. Keep it in mind, this is a question for exam. Believe it or not, sounds like simple, sounds like this is business, sounds like it is legal for many of you. Is being practiced, still practicing a lot, but it's illegal. So what this federal anti-kickback law exactly is? Well, if you see, let's read what it says right there, then I explain it in my own words. It prohibits individuals or entities, organizations from knowingly and willingly offering, paying, soliciting, or receiving remuneration to induce referrals or items or services covered by Medicare, Medicaid, any of these governmental agencies. So let me explain it to you in simple terms. If your doctor or the hospital doctors refer patients and they receive a compensation for it, the medical that says, hey, send me patients, and I send you patients, we are even. Or send me the patients and I give you a commission. Nobody's gonna know. That is illegal. That's called, the anti-kickback law. This is a kickback. Kickback is, you kick me and I kick you back. So if you refer me your patients, I'm gonna compensate you for that through money, gifts, any kind, the compensations. So that's basically what it is. So this happens more than you think. Medical doctors, they refer the patients to their friends, to someone else who's paying them or who they receiving some type of remuneration or compensation. And it happens a lot with referrals. And it makes sense, right? If you recommend me someone, then I will pay you a commission. I will give you something. But in the medical, it's illegal. So that's basically what it is. And this happens more often than you think. It's just that sometimes you don't get caught. Sounds like illegal, but it's illegal. It's not legal. It's illegal to refer patients to someone and then receive compensations from them. So that's one of the first ones. This is the anti-kickback law. So violation of this law could result in, this is serious. This is not something that you're going to be taking lightly. 5 to 10 years in prison. Fines up to $100,000 if you are, someone outside the medical, that you have business with the medical. So that will be a criminal penalty. Remember, medical providers are abide by the civil law, not by the criminal law. Because most of the things that happens in the medical is not intentionally, except for this, because this is fraud. And fraud is an intentional act for gain, just monetary or some personal gain. So that's basically what it is. Now, for the administrative part, for the civil, for the medical providers, it will be $50,000 and 5 to 10 years in prison. Oh, joy. Not good, right? Because it is fraud. Fraud is a crime. So that's basically what it is. Because you did it intentionally. This is not unintentional. An unintentional thing is you didn't mean to. But if you are receiving money, being compensated for referring your patients to someone else, then, or paying them to join you. See, right here in the area where I live, there was a dental office that they opened. I live in Forest Hills in Queens. So There was a dental office, very fancy dental office. I saw that right close to my building. I said, wow, this is really nice. I haven't seen this. So they were paying people. They were giving them $100 to $200 if they just come and use the insurance, even though if they didn't have anything. And they, they bill for services that actually they did not provide. Oh, we're gonna do cleaning, we're gonna do some type of denture cleaning, and they bill for a root canal, for some other stuff right there, some braces, of a lot of stuff. Next thing I know, I saw all the FBI around there. They raid the place, and it didn't last 2 years. They closed it. A lot of people went to jail. See? Fraud. Some other they don't do it that openly, but still they do it. But it's very serious. So for this federal anti-kickback, remember, this is just for referring your patients and being compensated for it. We're not talking about just regular fraud, but this is considered fraud because you are being compensated. Sometimes the medical doctor is gonna just, refer you to this specialist, even though if you don't need to go to the specialist, just because you're gonna get compensated for it. You're gonna use the excuse, oh no, the patient need it. I need to go to see this specialist, blah, blah, blah. But actually you didn't. It was because of the money that you're gonna get from this person that you're referring the patient. So you're gonna get paid for seeing the patient, you're gonna get paid for referring the patient for no need situation, and the other doctor is gonna be paid because they're gonna evaluate the patient because you refer them. So a lot of things going on, don't you think? So that's basically what it is. And the last that can happen to you, well, it's not the worst, but you're going to be excluded from participating in federal healthcare program. So you no longer, if you stay as a medical doctor or your office or your hospital, they're not going to be able to use any of the government insurances. So you cannot take patients from this insurance that are affiliated with the government. So you lose. Because Medicare patients and Medicaid, they have lots of patients. And these patients, even though if it is quantity, you're going to bring lots of them to your office. Utilization Review Act. Now, this is more likely for the things, the services that you're providing, how you misuse the equipment, the supplies, the sources that are being given to you. So that's basically what it is. For that reason, these hospitals, particularly the ones that receive these funds or these nursing homes, they are continuously being monitored. They continuously receive all these reviews, these audits, because they want to make sure that every single piece of equipment, money that they give it, they use it for the purpose that it was intended, not to use the money for some other issues that are not related to the care of the well-being of the patients. So that's basically it. It's not for you that I'm giving you all this money to this hospital. It's not for you to increase the salary of the people that work there, particularly the high rank people. No, it's to spend it in things that are needed for patients, to improve the installations, to improve the equipment for maintenance, to hire people that are needed if you have a shortage. That is Utilization Review Act, because they're going to see whether the money that I'm giving you, you are utilizing that the proper way. If you use them for the proper resources that are needed. So that's basically what it is. So you see, a lot of things goes on when it comes to these public or governmental funded organizations, because that's the money of the taxpayer. But it needs to be used, appropriately. Let's move on to something else. Very similar to the kickback, remember, law, we have the Stark law. Stark law. This is the physician self-referral law. Now, again, it says physician self-referral law. Before was you refer to someone else. And you're gonna get compensated for it. This is referring your patients for services that you own besides the medical clinic, or a relative of yours owns that particular, or a friend of yours. Let me give you an example. Not long ago, a medical doctor opens his office right here in this street, and next door he opens a pharmacy that was owned by the medical doctor. So all the patients that they were seeing, they send the prescriptions to this pharmacy because it was owned by the physician. So that is called physician self-referral law, or the Stark law. That is illegal. If the business that you are referring your patients, whether to a pharmacy, whether to physical therapy, whether a psychiatrist, whether rehab, whether a acupuncturist, anyone, you're referring your clients over there, you're sending them, you go to this place, you go sometimes without the need, because this is a family member or you own those business, then you are violating this particular law, which is called the Stark law. Think about it. So it happens a lot. Now they don't own the pharmacy. They put the pharmacy under someone else's name. So that's how they get away with. But you see, whenever you go to the medical doctor, you have a choice. The problem is sometimes the patient, because the patients do not have a pharmacy of their choice. Sometimes they don't know about these laws. So whenever the medical provider, kind of suggests, because they're not going to tell you, oh, you got to go to this one. They don't. They suggest, do you have a pharmacy of your choice where you want your medical? No, I don't. Okay, so we assign you one. Do you have someone, a medical doctor that, cardiologist or gastroenterologist or psychiatrist, psychologist, anyone that I'm going to be referring you to? No, I don't. So then you're going to refer to someone that you know, and this person might be compensating you. See, that's how things happen. So it is very difficult to know, because nowadays they do not put anything under their names, because that's a violation. That is called also conflict of interest. You own this business and then you send them to your other business. So everything stays at home, right? So that is illegal. And probably, you might think, oh, wow, I did not know that. But that's how it works. Oh. Any questions? Okay. Remember, turn the microphones off. Hello? Yeah, we might be hearing your in the background. Yeah, close your microphones so it doesn't distract the class. Okay, so that will be the physician self-referral law that is also known commonly as the Stark law. So remember these laws because these are very common for exams. So the Stark law, the kickback, they're gonna ask you, they're gonna give you a little sample and you're gonna have to know whether it's the Stark or the kickback. Remember, kickback is I refer you, you refer me, I get paid for it. The physician self-referral law, generally they don't use this term physician self-referral, they use the Stark law. So then you know that this is a conflict of interest. You or your family member owns business and you refer your clients to those businesses. So remember, it's not because you really need what you're referring there for, sometimes without the need, just for you to make some bucks right there. So that's how it works. So be careful with all this. So let's talk about OBRA. Well, the last time we see that is over. Oh yeah, the Omnibus Budget Reconciliation Act. So later on, we're going to talk about this in more detail, exactly what it is. But for now, this is under these acts that you have these laws. So this is another thing that is considered fraud. Think about it. So probably you didn't know. Now you will learn this. See, according to OBRA, this organization, 1994 added a waiving of co-payments, deductibles, and co-insurance as a lawful result in false claims, fraud. So let me tell you what it is. So if a medical doctor does not charge you for the co-payment, that is illegal because it's part of the billing process. It is part of the payment of the insurance to charge a co-payment. Now, remember, for the governmental organizations, if they don't pay you, it's because they have instituted. Back in the days, they pay the co-payment. Nowadays, they don't pay anything. But any other medical insurance that has a copay written on their cards and you don't charge them for it, it is called fraud. This is a violation, remember, or the anti-kickback statute or a false claim. So think about this. Now, why is that? Oh, wait a minute. I'm not paying the copayment, so the doctor is going to be penalized for that. Well, it sounds like harmless, but what is the purpose? I'm not paying the copayment. Well, you're not paying the copayment because if you're not paying the copayment, you are taking business from someone else and another doctor that is charging the copayment. And you're supposed to be charging the copayment, but you don't charge because you want to attract. You're going to steal the patients from the other office or hospital to come to you because you're not charging a copayment. Remember, copayment is obligatory. It is mandatory. It's not an option. If it's written on your insurance card, you must pay it. Period. Otherwise, you will incur in this type of false claim. Remember, this is fraud. So once again, if your medical doctor is waiving, it's not that you don't have the money to pay, or it's not that you're going to say, okay, you know what? I'm going to pay next time. But they're going to say, no, you don't have to pay the copayment. That's fine. And you don't charge it to your patient. You don't charge them because you don't want them to leave your office. Because remember, when it comes to payments, we do a lot of things for money. You as a patient, if they don't charge you this, then you go there. Think about the supermarket. The supermarket is charging you half of the price for the same product versus the other store. Where are you gonna go? You're gonna go to that one. But that's not a medical. That is not funded by the government, the supermarket. They are private companies. But in this case, because it's insurance and you're taking clients from, you stealing clients from your competitors, then you're going to be accused. Because if you're not charging the copayment, this client is going to tell the next one, oh, who's your doctor? Oh, I go there. And do you have a copayment? Say, yeah, every single time they charge me 20. Well, my doctor doesn't charge. I've been there for like 5, 10 years. They don't charge me. They never ask me about it. Oh, seriously? I'm going to move there. So that is fraud. That is like an anti-kickback. Okay, I'm not going to charge you, so I'm going to bring more people because of that. And my clients are not going to leave me because I'm not charging them for copayment. So you see, when you look at these situations in depth, then you're going to understand that's not just $25 for one patient. It's going to be 30, 40, 50, maybe 100 patients. And so that's a lot of money. And the other one is losing clientele and you doing the right thing. You're actually collecting the copayment because it's part of, the law, but you have to do it. But the other one is not doing it. So now you have problems because somebody else is stealing your clients. They're using this as a bait to do that. So that's basically what it is. Or that you are using too many services, for your clients that are not needed. So when you use these services and sometimes the medical doctor says, oh, no, it's a necessity. And they, document a bunch of stuff that is not actually true. Because you want your client to stay with you and you want to please them. And you're going to get paid for those services. Because remember, medical doctors make money when they order procedures. We don't make much money just with the visit, with evaluation and management fee. That's not how you make the money. You make the money with services. Why? Because I order a service, I get paid twice. Want to order them, I get paid. And then when I give you the results, I'm going to get paid. But if I'm going to be just examining you and nothing else, I'm just going to get paid once. But for any services that I do, I'm going to get paid more. And see, other anti-kickback violation. You refer your patients to this particular imaging center, because I know that. Oh, this imaging center, come and visit. The doctor says, listen, if you send your patients for MRIs, CAT scans, sonograms, x-rays, blah, 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 I'm going to compensate you this much for each test because each one pays different and they are very expensive. So then you receive some money from them. It's a kickback. Not only that you're going to refer your patients to another medical provider for those imaging. When you prescribe a medication because the pharmaceutical rep brought you something, if you gift, give you a treat, took you to some places, a restaurant, blah, blah, blah. Now, it's like bribing you for you to prescribe this medication that they are promoting. That is anti-kickback. See, all these violations that occurs in the medical, and we see it all the time. And we have to be at the lookout because that is illegal. And that affects the quality of care that we bring in or render to our patients because we're not doing it because the patient needed it. You are prescribing a medication because somebody else is paying me to prescribe this medication. So that's basically what it is. You put in a risk, people. Just because you're thinking about, you, the money. But you're not thinking about you, because if you get caught, you're going to lose your license and you're going to pay a fine and you over. So that's basically how everything works. So we have to be very, very careful. Remember this anti-kickback, remember? Very important in the start law. You need to know them because they're going to ask you these questions. They just want to know whether you learn this or not. They want to know that if you are assuming, because remember back in the days, medical assistants were in charge to complete these claim forms. Not anymore, not here in New York. They have a billing company that works on that. Other things that we use the medical records for, it is for physicians at teaching hospitals. So see, when our hospitals, well, every single hospital is a teaching hospital. Why is a teaching hospital? Where you have residents in there. Have you gone to a hospital where they don't have residents in there? Well, be careful with residents, because residents for some people means patients that are admitted. We can call it residents. But we are talking about medical residents, the ones that already graduated from school. Now they're doing their internship. Just put it that way. Internship is a residence for the medical doctors. So when we're doing the medical residency, we are going to be, seeing patients. And we are responsible for their health. We are going to be using the patient's information. You're still not a medical doctor yet. You are doing your training. That's what's called a resident. You have some type of certifications to do that, because you need to pass. That's part of your school. This is like you. When you finish these lectures, you get to go and do your internship. For the medical doctors is to do the residency. And you're going to be able to do a lot of stuff. With one difference, you're not going to get paid. Residents, we did get paid at that time. Every single resident get paid. You don't get paid as much as a medical doctor, but you get paid certain amount of money, more than, $50,000 per year. So that's basically what it is. So I'm just giving you an example of what the resident is all about. So audits implemented to examine billing practices at teaching facilities, because here we have to talk about insurance. Remember the documentation that we complete. So when residents or these teaching hospitals uses residents to complete the patient's history, the residents, as a residents, we do not sign medical records. Those medical records needs to be evaluated by a medical graduate. So someone who is a senior medical doctor, someone that we call in our field a preceptor. So every single resident is going to have a preceptor, is going to have a seasoned senior medical doctor who's been on the field, who already have a license, who is a medical graduate, to evaluate those medical records for us. And they are going to sign for us, because we are not allowed to sign them. So that's basically what it is. So again, think about this. How do we get compensated? Well, exactly like medical providers, because first of all, let's say we are still students. we saw the patient, we diagnose the patient, we send them to procedures after, the preceptor has evaluated them and they agree or disagree. If they are not agree with whatever we order, they're gonna, tell us what should we do, or we're gonna go back again and review and try to come out with the right answer, with the right procedure, with the right diagnosis, order the appropriate test. That's what they're going to review things. They're not just going to let you work over there. So that's a big responsibility, particularly for billing purposes. But the insurance is going to reimburse the hospital as a hospital. That's it, because they don't reimburse us in any single way. No one, no medical provider gets reimbursed directly if you work for a hospital. No one. You have to be the owner of the practice in order for you to be reimbursed directly by the insurance, because this is your practice. So you have to file, you have to apply for the insurance. And if you are approved by the insurance, then you can take clients from that insurance. So you have to be compliant with all these regulations from Medicaid and Medicare. That's basically what it is. So again, this is not the residents who actually diagnose the patient. You do, but it has to be evaluated, reevaluated by the medical doctor. If something is not right, meaning you don't have the right diagnosis or the right procedure, or you failed to complete the physical exam, you're missing something, you're gonna go back again, do it, and you're gonna come and present again the case to your medical preceptor. That's how it works. And then they will be able to bill for the services for the patient. So it's a little more, time consuming, because you might have to go back and forth to determine procedures, order tests, or come out with a diagnosis or treatment. But the work is going to be done. And it's billed a little bit different because, remember, it is a hospital and it's, taking a little more time, and it is a resident who's doing the job. So that's basically what. So little differences here and there. National Correct Coding Initiative. Now, once again, we're going to talk about the CMS, because the CMS is going to play a big role in, guiding or regulating what's going on directly with, the services that are provided by these insurance companies, and how we're going to claim for those benefits. So that's basically what it is. So this National Correct Coding Initiative, developed by the CMS. Remember, you need to know what a CMS stands for. It's the Centers for Medicaid and Medicare Services, to train down Medicare programs expenditures by detecting off-place codes on claims and rejecting payments for them. So this organization kind of plays the role of an audit. That's basically what it is. So they're going to be reviewing every single claim to make sure that you're not up coding, down coding, or just adding codes for services that were not provided. And if that happens, then they're going to reject your claim. Now, if they reject your claim, you can appeal your claim. So you can, kind of fight to get this evaluated again, because rejections are very, very, very serious. Now, if you make a mistake, or they might think that you make a mistake, they're going to ask you to do corrections. So you have to resubmit these claims. But when they are rejected, that is like, think about someone that was found guilty, verdict, guilty. So 10 years in prison. That's it. Your attorney is going to apply for a plea, right? So no, the damage is done. So now you can fight this, but it may not work. So it's very serious. Rejecting a claim. That means 99.9% we lost that case. We lost that reimbursement. So think about it. There is someone watching who is doing what, particularly with these claims, because it's money involved. So that is the National Correct Coding Initiative. That's what it says, National Correct Coding. Because it's a national level, they have someone who is actually monitoring all these codes that are used correctly. That the intention of this code is to pay for services that actually occur, that the codes are correctly used for the reimbursement. That's basically what it is. Any questions? Okay, so it's 9. We're gonna leave it right here. It's a lot of information. So little by little, we are going to disseminate, break down, deliver this information so you can retain some of the information that is the most important one. Okay. So any questions before we call it the night? Remember, I sent you already, I emailed you the exam. So you have until Sunday. See, I have a lot of time. So take your time, read it, evaluate it, make sure you know that you get most of the information. It's not difficult, 35 questions, and then you return it back to me. You don't have to wait until Sunday, just like most of you know. If you complete it before, you're welcome. I review it and I send you the grade. So that's basically what it is. Okay, so thank you so much for attending the class. Again, if you have any questions, let me know.